In grand rounds. It gives me great pleasure to introduce Dr. Dang. Dr. Dang is the Associate Director for Implementation and Outcomes Research at the Miami VA Geriatrics Research Education and Clinical Center, and an Associate Professor of Clinical Medicine in the Division of Geriatrics and Palliative Care. Dr. Dang earned a degree from the Maulana Azad Medical College in Delhi, India, completed her residency in internal medicine, and her fellowship in geriatrics in Rochester, New York, and Little Rock, Arkansas. She also received an MPH from Tulane University. Dr. Dang is a geriatrician with an interest in models of care for patients with chronic diseases, specifically using telehealth and care coordination. Please welcome Dr. Dang.
Thank you for that kind introduction, and thanks for having me today. So I'm going to talk about technology-assisted care coordination in chronic disease management in the little time that I have. I'm going to start off with good news and bad news. So the good news is that people are living longer because of advances in medical technology. The bad news is as they live longer, they develop chronic diseases, which then need additional care and lead to increased cost. In fact, 75% of the cost of medical cost in this country is from people who have one or more chronic conditions. And about 43% of the cost is from only 5% of the people who have multiple and complex chronic conditions. So we're going to go over some components of the chronic care model to care for patients with chronic diseases and discuss some examples of technology-assisted care coordination, and then kind of go over why it might be a good model and why it should work. So this is a patient in the VA who was 65-year-old who had multiple chronic conditions and had heart failure secondary to ischemic cardiomyopathy besides his other chronic conditions. He was enrolled in a program that we called My Healthy Heart. In this program, the patients were asked to enroll in My Healthy Vet, which is the VA's patient health record. And through this, they can enroll and get secure messages with their healthcare team, with their health provider, etc. And this patient, because of being in this program, received weekly educational messages on heart failure. They also responded to weekly questions about their heart failure signs and symptoms. The patient sent secure messages. Okay, this is confusing. Secure messages with their heart failure signs and symptoms to the nurse who, by secure message, who was monitoring the responses. And then she provided care coordination based on the responses that she got from the patient. So in this week, while responding to his questions, the patient answered that his weight was 159 pounds. He had some changes in his medications last week. He also had some increased shortness of breath compared to previously, and also was more short of breath than usual. In a secure message to the nurse care coordinator, the patient said he had a change in his medication and he thinks that this medication doesn't seem to be working as well as the previous medication that he was on, and he was taking 2 pills in the morning and 2 pills in the afternoon. This patient seems to be more educated and informed than our usual patient that we see who usually have no idea what they're taking or how many times they're supposed to take it. So this is an unusual patient, but this is an informed and activated patient, which we all kind of dream about while we are providing care to such patients. So the nurse sent a secure message back to the patient saying that your current weight is 159 pounds, your baseline weight is supposed to be 155 pounds, and on reviewing your records, we see that you were supposed to take 4 pills altogether, not 2 pills twice a day, until you return to this baseline weight. But because she was alerted to the fact that this patient was having some trouble, she was able to coordinate an earlier appointment in the heart failure clinic for this patient and also some blood work, and then asked him to call her if he didn't feel any better or go to the ER if things got much worse. So again, this patient, because of the change in medication, was not responding to the new diuretic, and because the care coordination effort actually helped preemptively have him come into the clinic and possibly prevent an adverse event. This is kind of what we expect care coordination to do. So as I mentioned previously, there are several problems with the current healthcare system, which has an increasing number of complex older patients with chronic diseases, and these are the patients that lead to a disproportionate amount of healthcare spending. This is especially exacerbated in the fee-for-service environment, which leads to increased fragmentation and duplication, where tests are repeated and patients are going into different healthcare systems to get their care, and often people don't know which end is up. This leads to increased healthcare cost and a system which cannot meet the demands that are needed by the patients. And in the midst of all this is this patient with this chronic conditions. The patients with chronic conditions are already dealing with their physical, emotional, psychological, and economic impacts of having the chronic condition. They have to manage their health condition, they have to manage their signs and symptoms, figure out what medications to take, how to pay for them, and deal with the emotional onslaught that having a chronic condition brings. And between all this, they have to navigate this complex healthcare maze, which is really, really hard, even for the best of us on good days. So it was shown in 1995 by Michael Rich in a group of really sick heart failure patients that a nurse or social worker directed multidisciplinary care coordination intervention actually can reduce hospital admission and significantly reduce cost and improve patient and caregiver quality of life. Therefore, this led to the chronic care model being proposed, which basically said that the care for these patients needs to be coordinated and continuous and not episodic. Our system was actually designed to take care of patients with every acute exacerbation, take care of the patient, send him home, and then see him when they got sick the next time. But the chronic care model proposed that that model wouldn't work for patients who had chronic diseases, and it really needed to be continuous monitoring and feedback to the patient in order to make them feel better and do a better job of improving their outcomes. And it also said that the most underutilized resource that we have in chronic disease management is the patient themselves, because you need to inform and activate the patient so that they are a partner in their care. And this can be done by providing self-management support to the patients. And really, this required a redesigning of the whole healthcare delivery system the way we know it. The patients also need decision support to be provided to them at the time when they need it so that they can make changes to their regimen, etc., so that they can prevent adverse events and have better outcomes. At the crux of this is this interaction between the patient and the care team, because if the patient has information that they're transmitting to the care team, there needs to be somebody at the other end who receives the information, processes it, and gives feedback to the patient to be able to make a difference or make an intervention that will then improve their outcome. So the traditional care coordination model was thought to be great, but as people tried to replicate the model, it wasn't always effective. In fact, about a quarter of the projects that were done were effective and the others were not. And this was because they required frequent contact and a lot of information sharing between the patient, the care coordinator, and the care team, which was difficult to accomplish by just using the plain old telephone system. And it was really expensive and difficult to sustain. So in the midst of all this, with all the advances in technology, it was thought that technology was now more usable, more affordable, and more easily available, and it could facilitate patient education and provide automated decision support, and therefore it may be a low-cost alternative to the traditional way in which care coordination was provided. So this is what a technology-assisted care coordination model might look like. In the center is the patient who is a high-risk, high-cost patient. Those are the patients we want to try to target with this model, who have any of these chronic conditions, which these patients require to be monitored, they require education, and they require feedback, and this can actually be provided via technology in an automated fashion by either the internet, by using home devices, by using a cell phone, by using a video phone. I mean, there are many different options for technology, and all of them work, some for different specific conditions, some for different patients. And these patients get information and education in the form of questions that they answer either every day, once a week, twice a week, reminders and tips about their signs and symptoms, about self-management behavior, and then they get some automated feedback based on their responses, which are all done by technology. The care coordination team is available to review the responses that the patient gives every day, or every week, or whenever, and is available to intervene and do care coordination when the patient needs it. But it prevents them from having to make phone calls that are unnecessary and not needed when the patient is doing well. They reinforce the education, support, and feedback. And to reinforce, the care coordination team doesn't have to just be a nurse or a social worker or somebody from, it can be a community health worker, it could be somebody who's a peer who has been trained in how to manage that condition better. And this model of care coordination then provides interaction and care coordination between the primary care providers, the specialists, the pharmacy to make sure that the patients have their medications, etc. And all this should lead to better health outcomes, decreased cost, and improved quality. The care coordinator may have such a screen where they log in and they review the patient's responses. They might have a panel of 100 to 150 patients, but these are the patients that they would focus on that day because the patient's responses are able to be risk stratified because of the technology into high risk, which might be showing up as red, medium risk, or low risk. And the care coordinator then knows that they need to call the patients who have the high risk responses and the medium risk responses, but actually don't have to worry about the patients who are responding within normal range. They might also be able to get graphs for the patient's signs and symptoms that they're monitoring. Such a graph which has so much red in it might preemptively prompt the provider to make changes in medications and intervene before the patient's next visit so that you can actually improve outcomes for such a patient. So we're going to go over some examples for technology-assisted care coordination. The VA actually has been a leader nationally in care coordination home telehealth, as this program is called in the VA. And the components of the program include care coordination and a home messaging device that monitors and educates the patients on a daily basis. There is no direct provision of services, so the care coordinator doesn't take ownership of the patient, but coordinates the care with their primary care providers. And the VA has done this for about 15 years now and on several thousands of patients. In one report that they published for 40,000 patients who had either diabetes, hypertension, heart failure, COPD, depression, or PTSD, they showed a reduction in admissions and bed days of care by about 20 and 25% respectively. So that was pretty remarkable. Now remember, this is a real-life intervention and there was no control group, so it was a pre-post study, and there are some limitations to how we can look at those results. We looked at the data from the Miami VA, and for patients who had diabetes and were enrolled in the program for over 2 years, and we showed that such a program, a telehealth care coordination program, reduces cardiovascular risk in patients with diabetes. It also improved their systolic and diastolic blood pressures and did not so much actually impact their lipids or their blood glucose in that evaluation. In another big study that was done, one of the larger ones that was done and funded by Medicare, in which they included over 1,600 patients with diabetes who got a home video conferencing unit and received care coordination or case management and were followed for 5 years, they showed that there was a modest but significant effect on the hemoglobin A1C, the systolic blood pressure, and lipids, and an increase in diet and exercise knowledge. But they were not able to show any benefit on mortality, and they were not able to show any benefit on cost. In a study that we did here at the University of Miami and the VA, in which we used peer leaders and mobile intervention for patients with prediabetes and diabetes, in which they were assigned to 3 groups. The patients got either just a peer leader, they got a peer leader with a mobile technology intervention, or they got usual care, and they were followed for 12 months. The patients' mobile intervention actually included them getting information on diabetes every day, so they had a menu of options that they could scroll down, they could get what their risk factors were, they knew how to manage their diet, etc. They were also able to monitor themselves for blood glucose, blood pressure, weight, and physical activity, and they had their goals established for them and that were given on the dashboard so they knew how far they were up against their goal. In this study, we showed that in the group that got the peer leaders and the mobile intervention, we were able to reduce the fasting blood glucose from 147 to 130, which was significant, and also a significant reduction in the weight. Interestingly enough, in this group, even in the peer leader group alone, without the technology, there was a reduction in the weight that was significant and in the body mass index. There were ethnic differences in effectiveness of different interventions, and we need to look more into those results. Moving on to a different condition, heart failure, which is one of the greatest reasons for readmissions for Medicare. In this study that was done at multiple centers, there were 460 patients that were randomized into 2 arms, and the home-based telemanagement group received education by the nurse, which was ongoing, and also the ability to transfer a 1-lead trace of an EKG to the nurse by a telephone. In the home-based telemanagement group, there was a reduction in the number of admissions compared to usual care and the lowering of the heart failure-related readmission risk, but there was no difference in cardiovascular mortality in this study. In a study that we did here at Jackson and UMH, in which we enrolled only 61 participants, this was funded by the state of Florida, to answer daily questions about heart failure signs and symptoms using a mobile phone. This study had all minority patients, mostly with lower education levels. And at 3 months, we were able to show a significant improvement in their self-efficacy for managing chronic disease. Their health distress score was improved, their quality of life, and their general health was improved. However, in another study that was coordinated out of Yale, they enrolled more than 1,600 patients who had recently been hospitalized for heart failure at 33 different cardiology clinics throughout the country. So these were regular cardiology clinics. They were not academic. These centers had to enroll at least 25 patients, and they received patient responses via interactive voice response system, which included daily information on their symptoms and weight. At 6 months, this study showed no difference in mortality or on hospital readmissions. And at 6 months, only 55% of the patients were using the technology, and 14% of the patients never, ever used the technology. So in this study, because the data was transmitted to these cardiology groups, it's not clear how the data were handled, because the nurses or somebody at these clinics received the information, but what they did with the information and how they acted upon it, and in how much of a timely fashion that was done, is unclear, and that may be the reason why it's proposed to not have worked. In hypertension also, it's been shown to work in this study that was done in Mexico and Honduras in patients who had low literacy. Patients were able to transmit their blood pressures on a daily basis, and it showed that they had a reduction in blood pressure compared to the control group, and that was also equal in the low literacy patients. They also improved their depressive symptoms, medication problems, and general health and satisfaction with care. In a study that's ongoing here at UM that we are doing, we are enrolling 300 Latino patients who've had a stroke before, and we're giving a cell phone intervention that's combined with a community health worker. The goal for this study is to reduce the risk of recurrent stroke by having the participants track their blood pressure, blood sugar, and weight on an ongoing basis. The patients receive educational messages, and the care is coordinated by a community health worker who tracks the patient's responses. So in this, some of the sample texts are the patients could get messages that say, how can you lower your blood pressure? The patient answers that by increasing physical activity, that's 2, and then the system automatically replies back saying that's partially correct. These other 2 options also will also help you lower your blood pressure. So you see where the automated responses actually help the patients understand the cause-effect relationship of what they're doing and how the system can respond to them without the care coordinator spending much time on this. So the community health worker would get alerted when the patient's responses are high. So in this instance, the patient kind of answered on a scale of 1 to 10. The patient said they answered 8, which means that they're sad. And so the community health worker would get an alert so that they could intervene and follow up with the patient to see if there was something they could do to help that situation. So why might a program like this work? So we know that from the patient perspective, it promotes engagement and self-management because it gives them tools to self-manage. It delivers information, reminders, establishes a routine, and it helps them track their health. It provides them automated just-in-time feedback when they respond into the system, and it provides decision support. So in a way, it helps promote and sustain behavior change and gives them a sense of accountability. From a provider level, it leads to earlier detection because things are being monitored on an ongoing basis, and with that actionable information, they can make a timely intervention. And the case management is by exception, so they only target the people who have the red responses and not everybody. At an organizational level, also, we feel that this could be more efficient and increase the cost effectiveness for populations. So in essence, this is the chronic care model, and it's proactive and continuous, and technology kind of helps that model. So even though we know that there's a lot of promise that technology-assisted care coordination holds, we know that the data are contradictory, as I just presented. There were positive studies and there are negative studies. We know that we can establish such programs. We also know that technology has limitations, but some of them can be overcome by training the patients, training the providers, changing the technology, etc. Technology can help in assessing, monitoring, educating, and supporting patients and can improve some outcomes. Engaging patients on a long-term basis in such technologies is always a challenge. And then there's several questions that still need to be answered on the who, what, when, how, and how often, and how long. So which are the best patients? What technology should you use? How often should you monitor them? Should it be every day? Should it be every other day? Should it be twice a week, etc.? And then we have to figure out their impact on cost and on at an individual, organizational, and a societal level. In the end, technology is just a tool. So in the middle of the circle is the patient, and the patient has to transmit information that would help manage their condition. The transmission has to be efficient. And the most important thing is here, where the information that's received needs to be acted upon by the team that's receiving the information. Because if their data are transmitted, but nothing is done with the data, then it's useless, and there's no good outcome to be gotten from that. And then the patient needs to make the intervention and complete the intervention, and the circle goes around again. So technology, again, is just a tool, but we think that it's a promising tool, and there's a lot of work ahead that needs to be done. But this work requires collaboration between everybody to figure out, establish priorities and roadmaps, to develop the best systematic protocols, practices, and standards, and develop evidence on impact, cost, who, when, what, how, etc. And then somebody's got to pay for it, so that might require healthcare reform, which, based on the recent election, is not going to happen. And then it requires some regulatory changes. It also requires that we develop interoperable systems and devices that talk to each other. Otherwise, we are going to have systems that don't talk to each other, and that leads to redundancy and duplication. So in the end, I'm going to end with the good news and the bad news like I started. The bad news is that the cost of healthcare for chronic diseases is going up, and it's unsustainable the way it is, and we need to do something about it. The good news is that we think that there are options to address this problem, and technology-assisted care coordination could be one such option, but we need to figure out how to best harness its potential and make it work for us, because it is here to stay and it's not going anywhere. As I've been doing this work, I've worked with many people who've taught me several things, and I want to say thanks to all of them. And then if you have any questions, this is what you do with them now. Thank you.
Thank you, Dr. Dang. That was very interesting.
Thank you.
As the population ages and it becomes more chronically ill, those tend to be the individuals that are less technology savvy.
Right.
And what I didn't see here, although you talk about low literacy rate in some of your population, how many people what percentage of the individuals who you approach just aren't really suitable for this type of technology?
I think that's a difficult question to answer, although it's a great one. I think we've seen that it really is not that much a function necessarily of aging, the ability to use technology, as it is a function of their education level often. So people who have access to technology and are willing to use it can sometimes be taught how to use it. They might, because they're older, need 2 or 3 sessions to teach them how to use it rather than 1 session. But again, you can always take a horse to the water, but you can't make it drink. So there will be people who will enroll in such programs but will refuse to use technology no matter what you do. And
is it half of the population, or is it a third, or 10%?
That are willing to engage or that are willing to enroll? I think the people who finally engage are about half, but of those that actually actively engage might be half of even that. Yes.
Any other questions? Let me ask you one more then.
Sure.
So here you have people that can be so motivated to learn how to use, on the other hand side of the coin, to learn how to use the technology and to communicate 15 times a day if necessary with a healthcare worker. But God forbid they should take their blood pressure medicine. So what do you account? How do you account for the apparent discrepancy between compliance with the the technology, but yet not with their health?
I think when you can answer that question, you can become a millionaire, but I don't know the answer to that question. I think you just have to try to keep reinforcing that and establishing that cause-effect relationship and hope that they get it at some point.
Okay, thank you very much. This is
Sure.
excellent.
Thank you.
It gives me great pleasure to introduce our next speaker, Dr. Bresta Miranda. Dr. Miranda obtained her MD at the University of Panama and then completed internal medicine residency and then endocrinology fellowship here at Jackson Memorial Hospital and University of Miami. Dr. Miranda joined the Division of Endocrinology, Diabetes, and Metabolism at the University of Miami in 2005 and is currently the director of the Diabetes Education Center and Diabetes Research Institute. Dr. Miranda's practice is focused on complex diabetes management, and she has closely collaborated with the Adult Cystic Fibrosis Center, managing numerous cystic fibrosis-related diabetes patients through direct referrals to the center. Please join me in welcoming Dr. Miranda.
Okay. Thank you very much for having me today. We're going to be talking about cystic fibrosis-related diabetes. JD is a 41-year-old woman who has cystic fibrosis, who is referred for evaluation to us for abnormal glucose tolerance test. She has pulmonary manifestations with bronchiectasis and recurrent pancreatitis. She also has a history of Mycobacterium abscessus infection, has never grown Pseudomonas, but is recently growing Serratia marcescens. Her PFTs, when we saw her, were at baseline, and she denies any classical symptoms of diabetes. She has no family history of diabetes and autoimmune diseases. Her weight has remained stable. Her BMI has ranged between 21.5 and 21.8 in the past 3 years. Her physical exam is unremarkable. There was no evidence of insulin resistance. These are her labs dating 3 years prior to her initial visit with us. If you can see, she has had mildly abnormal A1Cs in what we usually call prediabetes range. Her fasting blood sugars have always been low. She has a couple of blood sugars in CMPs that are elevated, but with those samples, we usually don't know if the patient was fasting or not. She has had a few oral glucose tolerance tests, and she has progressively gotten worse in the past years with her 2-hour OGTTs. The last one, which was the one who prompted the referral, she had a 215 blood sugar. So does she have diabetes? Does she meet all the criteria for diabetes? If she has, what type of diabetes she has, and how should she be treated? So we're gonna discuss cystic fibrosis-related diabetes and try to understand the pathophysiology and the difference between this type of diabetes and the most common forms of diabetes that we are accustomed to treat, type 1 and type 2. And recognize that it needs to be screened, and there must be proper screening technique and diagnostic tests that we should use. We also need to establish a specific and unique therapeutic management and goals for these patients, which might be different from our patients with type 1 and type 2 diabetes. And also, it's important to know what kind of complications should we expect in these patients. So cystic fibrosis is a recessive genetic disease caused by a mutation in a CF transmembrane conductance regulator. This is a protein that is a chloride bicarbonate channel that is extremely important in regulating the content of the epithelial cell secretions. So when there is abnormalities in this CFTR gene, there is alterations in the secretions, in the ionic composition of the secretions in lung, gastrointestinal tract, liver, and pancreas. So there are multiple mutations associated with cystic fibrosis. They are traditionally classified in groups or classes from 1 to 6, depending on where the defect is. The more severe forms are between class 1 and 3, in which the CFTR protein is actually, the function is completely absent. And the phenotypic presentation or the severity of these classes is worse in the 1 to 3. And they are commonly also associated with cystic fibrosis-related diabetes. So cystic fibrosis-related diabetes is a common comorbidity in these patients and is distinct from type 1 and type 2. The most important thing about this is that it is associated with increased morbidity and mortality in children and adults. Now, why is this? We don't clearly understand. We know that in the cystic fibrosis patients, the lung function is very intrinsically related or dependent on the nutritional status of the patient, the ability to maintain normal weight and good lean body mass. So when we have insulin deficiency, insulin is an anabolic hormone. So these patients have, with the insulin deficiency, we are promoting a catabolic state that interferes with the nutrition of these patients. Also, the hyperglycemia itself might be contributing to the worsening of the lung function of these patients. There has been suggestions that the hyperglycemia promotes the growth of pathogenic agents that contributes to the recurrent infections in these patients and also promotes oxidative stress. The other question would be, is just a marker of a more severe disease, which is something also that we should consider. So these are data from mortality in patients with cystic fibrosis. The solid lines are patients who have cystic fibrosis and cystic fibrosis diabetes. The dotted lines are the ones without the cystic fibrosis diabetes. Red are women, blue are men. Traditionally, it has been thought that women had worse prognosis when they developed cystic fibrosis-related diabetes, but in the later years, the difference between men and women has been narrowing. And also the difference in mortality in patients with cystic fibrosis-related diabetes is narrowing a little bit, but you still can see that there is increased mortality in these patients. So what are the pathogenic mechanisms? How does these patients develop diabetes? There is a definite decreased beta cell mass, and also there is beta cell dysfunction. And traditionally, what it has been postulated as the main mechanism for the development of diabetes in these patients is that they have thick secretions that produce occlusion in the pancreatic ducts, and then digestion of the cells causing fibrosis and amyloid deposition. They have decreased whole islet cell mass, so they don't only are deficient on insulin, but also the alpha cells are affected, so they have low insulin and low glucagon. The other aspects is that there is also oxidative stress in these patients causing beta cell dysfunction, and there is an enteroinsular axis. For us, for the endocrinologists who manage diabetes, we are very aware of the incretin effects of hormones that are secreted at the gastrointestinal level that are important modulating the secretion of insulin at the islet cells in the pancreas. So in this in cystic fibrosis, it has been recently observed that there is a blunting of the incretin secretions, and that has been observed in patients with pancreatic insufficiency, and it's believed that it has to do with the effects on this enteroinsular axis. And interestingly, when they have replaced patients with pancreatic enzymes, they see some normalization of the incretin effect. So it is postulated that patients with pancreatic insufficiency have also low incretin levels. And also, there is the postulation that the CFTR have a role in the actual islet cells. And what is believed is that it just primes the insulin secretory aspects, and it just contributes to the initial first phase release of insulin. So this is just an example of what happened when the islet is stimulated by glucose through the GLUT2 transporter. There is a cascade of events that end up in the calcium channel voltage changes that promotes the release of these granules. What some people propose is that when there are CFTR defects, then there is no priming of these granules, and it gets blunted, the insulin secretory, the initial phase of the insulin secretion, what we call first phase. So these patients are usually, and commonly, their main problem is postprandial hyperglycemia. So in general, if we try to compare type 1, type 2, and cystic fibrosis diabetes, we can see that there are differences in terms of the islets. In type 1, you have the autoimmune destruction of the islet cells. In cystic fibrosis, there is this destruction of the islet cells, but mostly for a fibrosis process, and also a potential beta cell defect. There are also some difference in terms of insulin status. We have complete deficiency in patients with type 1 diabetes. Patients with type 2 have relative insulin deficiency, and they have insulin resistance. Patients with cystic fibrosis diabetes don't have absolute insulin deficiency. They are partially insulin deficient. And then the insulin resistance is variable. In the stages in which they are at healthy status, they are quite insulin sensitive. But whenever they have exacerbations or we treat them with steroids, then the levels of insulin resistance increase significantly. So that makes them a little bit different than your typical type 1 diabetes. Now, something that is also important is that a patient with cystic fibrosis is not excluded from the possibility of having type 1 diabetes. Which is something that doesn't happen usually, but they have the same risk that anybody else in the population have for developing type 1 diabetes. So if you have family history or some elements of the risk factors that you believe that the patient may have autoimmunity, it would be important to identify if this patient has really cystic fibrosis-related diabetes, or if it may have a minimal risk of having type 1 diabetes and do antibodies. Why would that be? Well, patients with type 1 diabetes are more prone to ketosis and are at risk of ketosis, versus patients with cystic fibrosis diabetes have very low risk of developing ketoacidosis. So how do we diagnose it? The most important thing is that the clinical symptoms are very insidious, and then screening is important. The recommendations for screening is to start screening at age 10, and it should be done every year with glucose tolerance tests. There is estimated that after puberty start, there is a 5% increase in the incidence of the presence of diabetes every single year. Nowadays, with cystic fibrosis patients living longer, so the percentage of patients with diabetes is also increasing significantly. And what we know is there is a spectrum of the severity of disease that starts even before we're able to diagnose the diabetes. And there is estimations that anywhere between 2 to 4 years before we are able to diagnose the cystic fibrosis-related diabetes by the standard oral glucose tolerance test, the patients have already started to have some decline in lung function and the nutritional status. So how do we screen? There are many different ways that we use to screen for diabetes in general. We generally like the fasting blood sugar and the A1C because they are easy tests to perform. However, in cystic fibrosis, these tests are not reliable enough. Patients with cystic fibrosis tend to have lower A1Cs than normal people. About 70% of patients who have been diagnosed with cystic fibrosis-related diabetes by OGTTs have A1Cs less than 6%. So A1C is not sensitive enough to do diagnosis on these patients. Fasting blood sugars are not sensitive enough either. These patients tend to have more problems with postprandial hyperglycemia, and they tend to have low fasting blood sugar. So we will not be able to diagnose these patients with those tests. So far, the only recommended standard diagnosis is doing oral glucose tolerance test, and the diagnosis is made by normal standard values. So 2-hour value of more than 200 is what is considered to be diabetes. Interesting, like the current recommendations is that if you find an abnormal glucose tolerance test, you should repeat it, which is a cumbersome thing to do. And we don't have a way of using the other two tests to try to help us at avoiding having to repeat the OGTT, but those are the current guidelines. Now, there are some authorities that are promoting to use shorter intervals in the OGTT at intermediate times, 30, 60, and 90 minutes, because there have been some observations that the first hour elevation up to 198 after a glucose tolerance test correlates fairly well with decline in lung function. However, there are no long-term studies validating this type of diagnosis. And in diabetes, we have now the use of continuous glucose monitoring systems. They're very easy to use. They are widely available at this moment. And there are also some people investigating if we can actually found what are the profiles that we can identify these patients in an earlier fashion. And also, it would be very easy to do, but there is no studies validating and what would be the targets or what would be the percentage of hyperglycemia that we would consider to be as diabetes. So these are the American Diabetes Association diagnostic guidelines for patients with cystic fibrosis and diagnosing diabetes. If you see like a patient with a fasting glucose of more than 126 or an A1C of 6.5, that's diabetes. We don't need to do anything about it. If it's normal, doesn't tell you anything, you should do oral glucose tolerance test. If the patient is in the hospital, then, and if has blood sugars above diabetic targets, 126 or 200 for more than 48 hours, you consider that that patient has cystic fibrosis-related diabetes. If the patient is getting tube feedings, which is commonly done in these patients, then you check the sugars at a midpoint, and if it's above 200, you also consider that to be CFRD. And for pregnancy, there is the more stringent criteria that we are accustomed to use. Something that is interesting is that about 25% of the patients that this year qualify to have cystic fibrosis-related diabetes by OGTT standard, the next year will repeat it, and they don't meet criteria for cystic fibrosis-related diabetes. So there is about 25% variability in the OGTT. The recommendations are that the first time that you diagnose the cystic fibrosis diabetes, that's the time that you consider that the patient started having the diabetes. So even though it normalized later on. So are these criteria appropriate? We are mainly using criteria that are common for other forms of diabetes. However, in cystic fibrosis, the lung is the target organ, or one of the target organs, not the only one, but is one of the target organs. And there are some interesting studies showing that there are lung thresholds, the same way that we have a kidney threshold for glucose excretion. There is a threshold in the alveoli for glucose passing through the lung space. And in cystic fibrosis, it has been observed that it's quite low. In normal population, it is believed that this threshold is anywhere between 152 and 180, and also in diabetic people. But it is believed that because there is some inflammation going on in these patients, that the threshold is lower. So they have a lower threshold, and they have the promotion of pathogenic bacteria when they start accumulating glucose in the lung space. So it might be reasonable to think that we should have more stringent criteria to diagnose and to treat these patients. So once we decide that we need to treat them, what are the goals that we should attain? The current recommendations is that we should just follow diabetes guidelines for treatment, and those recommendations that we have for the targets that we commonly use are based on the reduction of microvascular complications in diabetes. And that's where we get our less than 7% A1C target. And this is the same reasons that we try to individualize the management of our patients based on risk of complications, micro and macrovascular complications, and the treatment. In patients with cystic fibrosis, traditionally has been said that they have lower incidence of microvascular complication. Now, what we know is that if the patient has cystic fibrosis-related diabetes and the fasting glycemia is normal, they do not develop microvascular complications. But if they have evolved to have fasting hyperglycemia, then the incidence of complications is quite similar than patients with type 1 diabetes in terms of retinopathy. They do have more microalbuminuria, but there is microalbuminuria is related directly to the cystic fibrosis, not necessarily to diabetes. And they have lower incidence of high blood pressure. So in general, if we want to prevent microvascular complications in these patients, an A1C of less than 7 would be appropriate. If we want to think about the lung, then maybe a more strict criteria should be thought. These are the goals set up, which are similar to any other diabetic patient. And so when we decide the treatment, what do we want? We want to control the sugars, but we also want to preserve lung function and optimize the nutritional status of the patient. Prevent microvascular complications, we know that they can get it. Now, what about macrovascular complications? There are no descriptions of macrovascular complications in CF patients. And you would think that this is because these patients have not lived long enough. We don't have an aging population in this group, and that's why they haven't had the time to develop the macrovascular complications. There have been some studies in which they have done cardiac catheterizations. They have looked at the catheterizations of patients undergoing heart transplant, and they haven't found any evidence of vascular disease in these patients. However, now there are new medications for treating patients with cystic fibrosis. They are living longer, and this is a question that I don't think that we have an answer yet as to, do they have risk? Should we be starting being aggressive with lipid management and other factors later on in life for these patients? So the only recommended treatment for these patients is insulin therapy. They have done studies comparing with sulfonylureas. There is some theories about using incretin mimetics, but at this moment, the only recommended therapy is insulin, not only to prevent the postprandial hypoglycemia, but also use it as an anabolic agent that promotes a better nutritional status for the patients. So we talk about that. And this is a study in which it was published in 2009. They took patients who have cystic fibrosis-related diabetes without fasting hyperglycemia. This is the upper panel. Red would be treated with insulin, blue was Prandin, and black was no treatment at all. They were all starting to decline in BMI, and then once they started treated with insulin, and it was pre-prandial insulin, no basal insulin at all for these patients, there was some improvement in the BMI. The second panel, the panel B, is patients who have impaired glucose tolerance. They didn't meet criteria for diabetes, and they didn't see significant improvement on those patients. So since then, there has been some recommendations of treating these patients, even though they don't have fasting hyperglycemia. So when we treat patients that are insulin deficient, traditionally we use basal bolus protocols, in which we more or less give half of the insulin doses as basal, and the other half we give it in prandial use. That would be the way to treat the patients. However, in cystic fibrosis, it might be a little bit different. They sometimes don't have fasting hyperglycemia, and we might start with prandial insulin before we add the fasting insulin. If you look at the literature, there is a wide variety of different approaches. No, there is actually not one clear recommendation that this is the way that you should do. But in general, they use a little bit less units per kilo of insulin in normal states, but they can use very, very high doses of insulin when they are sick or with the steroids. You can start with meal coverage only if the patient does not have fasting hyperglycemia. If the patient has fasting hyperglycemia, then a basal bolus protocol would be okay. Some authorities use tiny amounts of basal insulin in the cases with fasting, normal fasting glucose, trying to cover for the needs of the patient with that. I personally stick with using the basal once the patient starts having the fasting hyperglycemia. When the patients are in tube feedings, they tend to use the tube feedings overnight. They do it in periods of anywhere between 8 to 12 hours. So using MPH is a very convenient insulin to use because it helps cover the tube feedings overnight, and the patient doesn't have to be checking in the middle of the night and sticking themselves to give more injections of insulin. And for steroids, frequently in the hospital, they will receive steroids. One approach that I think that we were using it before Lantus came on board, and then we stopped using it, and now we're going back to, is using MPH at the moment of the injections of the steroids, which works fairly well. Something else that is very different is the dietary recommendations. And this is one of the things that patients come a little bit apprehensive the first time that they come to see us, which is that they think that the diabetes doctor is going to start restricting their diets. We don't restrict diets on patients with cystic fibrosis, versus we do it somehow in the patients with type 1 and type 2 diabetes. We are concerned about our type 1 and type 2 diabetes patients gaining weight. We actually want our patients with cystic fibrosis to gain some weight. We're happy when that happens. Their total caloric requirements sometimes are up to 200% of the usual recommended doses. We don't restrict fat on them. They have liberal fat intake. We don't restrict proteins, and we don't restrict salt. So it's quite a difference between the usual way that we manage our other patients with diabetes. So what is the patient approach? Our initial goal is to promote weight gain and improve the nutritional status of the patient to help prevent lung function decline. Insulin is key. First visit, we usually have to convince these patients that they need to go on insulin, even though they have absolutely no symptoms of diabetes and their fasting sugars are normal. We usually enforce, and we are not going to restrict their intake, and we have to start diabetes education with emphasis in carbohydrate counting. This is another burden for patients who already have several things to manage in their disease, chronic disease. So we have to be sensitive about that, and we try to provide them with all of the things that we nowadays have available for managing diabetes. We have pumps, we have sensors, we have continuous glucose monitoring, smartphones. There are applications in iPhones and Androids. All of those things are tools that we can use to help the patients deal better with counting carbs and calculating insulin doses. So what happened with our patient? We instruct her in basic carb counting. We put her on a 1 unit for every 20 grams of carbs above 30 grams. This is kind of an unorthodox way of doing these things, but I have found out that it gives the patient the possibility of having a snack, for example, and not having to cover when they are starting the insulin. Sometimes they are afraid of having hypoglycemias, and they feel that they have this cushion of 30 grams of carbs that will protect them from if they overdo with the insulin. And because they are very sensitive, sometimes the ratios are 0.5 units per 15 grams. So it might not, we're not doing that bad by giving them a slight leeway with the carbs. This pass really fast, and eventually we just give them a straightforward ratio. But to start the patients, I have found out that they are very sensitive to start this way, and they do it. We didn't give her any basal insulin, and we asked her to check her postprandial. She actually she's very good. We saw her 4 months later. She was using anywhere between 2 to 3 units of insulin with her meals, good blood sugars. She gained 4 pounds, and her A1C came down to 5.4. She was about 5.8. And interesting, I was looking at the chart, and I saw this note from our pulmonary colleague at the same time, 4 months later, and he described her as happy with her current state of health, and big difference. She started feeling much better once she started using insulin. So they continue using the insulin afterwards. So at the end, we have managed patients with diabetes. Usually we are concerned about microvascular disease, and we target blood glucose control for that. For macrovascular disease, we know blood pressure, lipids, other risk factors. We don't know what to do there with the patients with cystic fibrosis. And then we have to add the loan, and maybe more strict glucose control is necessary. Thank you.
Thank you, Pressa. That was excellent. As people are thinking of questions, so in the patients that are diagnosed early on, before they are actually, you start them on insulin, but before their fasting glucoses are elevated, is there any role for other agents in the treatment before going to insulin, and what is the criteria that you use to decide?
So in general, most of these patients so the clinical recommendations is no, you need to start on insulin, because that is what has proven to have some beneficial effect in nutrition and pulmonary function. Now, they are investigating about using incretins, for example. The problem with the incretins is that maybe if you use DPP-4 inhibitors will be fine, but if you try to use GLP-1, for example, these patients are already losing weight. We don't want that effect. They have sometimes problems with gastric emptying, and so it gets to be a little bit more confusing. However, it's something that is being investigated. Use of sulfonylureas has been already compared. There is no benefit of that, but the new agents that we have, we don't have good evidence to support their use. Now, once in a while, you will have a patient that it has cystic fibrosis and doesn't have it's not losing weight. Actually, it's a mildly overweight, has a strong family history of type 2 diabetes. So in those cases, sometimes you may decide to use metformin, but all of those things are out of the recommended. Exactly.
And genotype, is that at all helpful?
Well, not for diabetes itself managing. They are using these new modulators, the ivacaftor, the lumicaftor, things that are improving overall the health on these patients. And there has been some descriptions of improving of the cystic fibrosis with the use of these agents that modulate the CFTR. However, I think that it's too early probably in the use of these drugs. They haven't been used for a long time, and most of these patients already have some damage to the pancreatic cells. So we cannot know yet if they will have some also effect on that.
Thank you. I'd like to one last question. Yeah, Alejandro.
So do these patients have problems with hypoglycemia and glucose counter regulation?
They have normal glucose counter-regulation. They don't have the glucagon, which promotes them, puts them at higher risk of having fasting hypoglycemia. But in terms of catecholamine response, they do have normal responses to hypoglycemia. There are some descriptions, and I personally have observed, I remember studying that there is no such thing as reactive hypoglycemia, but there are some descriptions of these patients having reactive hypoglycemia before they actually meet criteria for diabetes, because they have initial very, very high spikes on the blood sugars and then delay secretion of their insulin with reactive hypoglycemia.
I'd like to thank both our speakers this afternoon. Thank you very much.